and that's pretty inequitable.
Right.
Operations are high. So what does a poor person do? Do you pay the rent, or do you try to get your prescriptions? Do you go and see the doctor, or can you afford to see the doctor?
Come on, amen.
Or does the emergency room at the local city hospital become your primary care? The ER. So does the emergency rooms in the cities become primary care doctors? So there's something wrong with the platform, and we're glad today that we have a distinguished person with us, Dr. Friedman.
That's right.
And at this time, Brother Bob is going to introduce Dr. Friedman, who will share some information with us about what's going on, how we can overcome this, and do they have the money to pay for this? How many people believe they have the money to pay for this? Say yes with me.
Yeah.
Do they have the money to pay for this?
Yeah.
Do they have the money to pay for this?
That's right.
Do they have the money to pay for this?
Yes.
Good afternoon, my brothers and sisters.
Good afternoon.
I first would like to thank this church for inviting us and having us in today. This has always been a church that had open doors for those of us who have always tried to make a better world for justice. And this church has been known for that for as long as I can remember, and I've been around quite some time. I must first tell you that I'm not feeling too good today. This is not one of my best days. I just had an 85th birthday. And they always told me that old age creeped up on you, but I think old age ran up on me. But I had to be here. As Dr. King said, my conscience wouldn't allow me no other choice but to be here this morning. And I must say that we don't always worry about the size of the crowd. It's the size of the commitment. It's what really matters. I'm here today because Dr. King said of all the forms of inequality, injustice in health care is the most shocking and inhuman. Dr. King also said that truth crushed to the ground will rise again.
That's right.
And today we have a truth teller with us.
Okay.
Dr. Gerald Friedman, Professor of Economics, University of Massachusetts at Amherst. Professor Friedman was a Phi Beta Kappa member and magna cum laude graduate of Columbia University. He obtained the doctorate from Harvard University, where he received a certificate of excellence in undergraduate teaching. And the best thing about that is he is here with us today.
That's right.
He came all the way to be here with us. And we're so proud to have him. So let's give a warm Louisville welcome to Dr. Professor Gerald Friedman.
Thank you. Thank you so much. I'm quite humbled to be here in the steps of my brothers and where Reverend Martin Luther King spoke. I'm from New York, obviously. I hardly ever cross the Hudson River. And I almost never been south of Mason-Dixon. But when I was growing up, as a kid, I did have cousins who crossed the Mason-Dixon line, and one of them, my cousin Zeb, spent time in recouping from injuries that he suffered in a prison in Mississippi. He walked with a limp for the rest of his life. He was beaten in prison after taking off a Freedom Ride bus. I was a kid, so I loved my cousin, and we would talk, and he played toy soldiers with me. You know, Union always won over the Confederacy. Zev told me stories of, well, when he was in Vicksburg, and when he was in Jackson, and Champions Hill, and that was all very exciting to me. It was 100 years after the Civil War, and we were still on the march to freedom. March continues. It was 100 years ago, a little more than 100 years ago, that we began the march towards universal health care and health equity in America. Theodore Roosevelt campaigned for universal health care as a candidate of the Progressive Party in 1912. The campaign has continued. We've made progress. We enacted Medicare and Medicaid in 1965. We enacted the Affordable Care Act, Obamacare, in 2010, and we defended it miraculously from Republican attempts. The Trump administration made it be cursed and hell. We defended it, and we're continuing to defend it. And it is time, long past time for freedom in America, and long past time for health care equity for all Americans. And that's what we're trying to do with improved Medicare for all. And I have slides here, yes, there we go. Okay. And here's what we're talking about. Life expectancy for different countries, affluent countries, we're only talking about the relatively rich world, as a function of how much you spend. And the line shows the average relationship. It is upward sloping because the more you spend on health care, the longer people live. You buy more health care, people live longer. That should not be a surprise. It is a surprise to economists, but we're weird. Yeah. There's one exception, and that exception is why so many American economists dismiss the relationship between healthcare spending and healthcare outcomes, because it doesn't work in the United States. What I observe those who are 85 or even 64, we go for the years. I want 6 more years. Young people who are paying off their college debts or still saving to buy a house, I'll take the $7,000. Okay, things are getting worse. Back in 1995, we were average. We were spending a lot more, but at least we were living at least as long as average. Now, it's gotten worse. We're falling behind the rest of the world. And in fact, if you extend this another couple of years, life expectancy is falling in the United States the last 2 years. You know, we're losing ground relatively, and we're losing ground absolutely. And it's not because we go to the doctor so much. I mean, a lot of economists will say, oh, we spend so much money because people abuse the system. Grandma, this is what a famous economist, advisor to president, said to me once. Grandma gets lonely, so she goes to the doctor. Why is it always grandma they pick on, not grandpa? Yeah. But no, we don't go to the doctor that much. In fact, the people who live the longest in the OECD, the Organization of Economic Cooperation and Development, are the Japanese. They go to the doctor, they average 12 physician visits per year per person. And they live about 8 years longer than we do. Maybe there's something to it. But we only go 4 times a year, while other countries, they average over 6 times. You know. We're paying more for less. 30%, over 30% of Americans experience access problems because of cost. They could not afford to go to the doctor when they needed to. They could not afford to go to the specialist the doctor recommended. They could not afford to fill the prescription the doctor or the specialist recommended. I've heard stories from a receptionist of people walking out of her doctor's office, taking their prescription, looking at it, shaking their head, and dropping it in her wastebasket.
Come on now.
Because they could not afford it. They knew they could not afford it. Worse, there are people who get the prescription for something like insulin, and they think, well, I can't afford to buy my next dose, so I'll stretch out my old dose. You know what they call people who stretch out their medications or don't fill prescriptions that they need? Dead. Okay, why is this happening? It's happening because this is the policy we've adopted in this country. Instead of fulfilling the dream of Theodore Roosevelt, the dream of Franklin Roosevelt, the dream of the Reverend Martin Luther King, of taking healthcare out of the marketplace and making it a human right. Instead of that, we've commoditized healthcare. We've turned doctors into sellers to consumers. We've turned patients into consumers. I was just at a hospital this morning, and they have consumer help or something like that at the door. You know, here's a desk where consumers go for help. I'm not a consumer when I go to the doctor. I'm a sick person who needs help. I'm a patient, not a consumer. I'm a consumer when I buy a Zappa.
Like, come on.
I'm a patient when I go to the doctor. So, for 50 years, we've reorganized healthcare to respond to market incentives. And now there are two things here. There's first, we've given for-profit health insurance companies, monopoly drug companies, monopoly hospitals, we've given them power over healthcare.
That's right.
So they can make profit out of our sickness. The second thing is more subtle. We've taken healthcare out of the area of human rights and turned it into something you get because you pay for it. Nobody expects that everybody should be able to get a Zappa like this. If you have the money and you want it, buy it. If you don't have the money, whatever, you don't have it. Not everybody can go skiing. It's expensive. Not everybody can have a pony. Although I did promise one to my wife when we got married. That's okay. But when it comes to medication you need to stay alive, shouldn't that be a human right?
That's right.
Yes, sir.
Yeah.
When we turn healthcare into a commodity, we're rejecting that idea. And when we reject that idea, we reject the idea that we should be looking at the treatment of people as something that matters for their intrinsic humanity. So it's okay to discriminate. It's okay to mistreat some people. You know, what the hell? This is a business. If my ski area is unfair to women, well, okay, I'm going to go someplace else. I have daughters, I have a wife, I care about these things. But, you know, it is also a little bit of a market thing. If a hospital discriminates against you because you're black, and it's just a commodity and you're a consumer, then, well, okay, you know, maybe not nice, but if healthcare should be treated as a human right, then everybody deserves fair treatment. When we turn it into a commodity, we move away from fair treatment for everybody. It becomes a problem of the marketplace, where healthcare should be a problem of intrinsic human liberty. Now, what have we done? We use the market. And you know what? It doesn't even work. You know, of my teachers in graduate school was Kenneth Arrow. He wrote a paper on healthcare, and it's one of the most widely cited articles in economics. It's like Mark Twain called a classic, something everybody talks about but nobody reads. If they read it, then they wouldn't do the policies that they do. Because he said, healthcare can't be treated as a consumption activity. It can't be treated as a market commodity. Healthcare is different. And surprise, surprise, he was right. When we treat it as a commodity, it's just made everything worse. Insurance company competition doesn't lead to efficiency. It leads insurance companies to seek out the sick and discriminate against them. Get rid of them, because sick people are the people who are going to cost you money. Insurance companies aren't even effective at restraining prices. Elite hospitals like Massachusetts General Hospital, the Harvard Teaching Hospital where I live, they charge outrageous prices. And if we treat healthcare as a commodity, then we just say, okay, you don't want to pay that prices, do something else. Instead of saying, well, some people need to go there because of their conditions, so they should go there. And the hell with the prices. And utilization review, this is what insurance companies do. They tell doctors not to treat you. They tell doctors not to give you the drugs you need because they, oh, this would be cheaper. Why don't you give that person this? Even if that's not what you need. Okay, Americans die because they don't have health care. It's another one of those graphs that my wife was concerned about. Every county in the United States. And what we have here is the percentage who can't afford to go to a doctor because of cost, whether they have insurance or not. And up here we have the mortality rate in the county. Guess what? Counties where more people can't afford to go to the doctor because of cost, people die more. We are killing Americans with co-pays, deductibles, and not letting them afford doctors. Here's Kentucky. The same thing. You know, technically, the regression line is almost the same. Here's every county in Kentucky. Here's the percentage who can't afford to go to the doctor. Here's the mortality rate. Counties in Kentucky, if you can't afford a doctor, you die. Because we're treating it as a market commodity, not a human right. I mean, if you draw a line here of people who go skiing as a function of how much money they have, it would be upward sloping, just like this. Counties with richer people ski more. Okay, does anybody care? No, that's a commodity. It's not a big deal. It's like, yeah, I love to ski, but it's like, not everybody can afford to go skiing. I'm lucky, I have money, okay, fine. But when it comes to healthcare, it's not the same bloody thing. If you get sick, you should be able to go to a doctor. That is part of the promise of America. This is what we fought wars for. This is what Reverend Martin Luther King died for, so that everybody would have the right to fair treatment, which has to include the right to live. And the right to live has to include the right to health care, or else it means nothing. Okay. Oh, God, it gets worse. This shows the change in life expectancy at age 55 over the last 20 years. For men and women, according to how much money they have. The rich are living longer. The blue line is men. The, what is this? Orange? The orange line is women. Rich people are living a lot longer. Actually, rich Americans, these are the richest 10% of Americans, they have a life expectancy comparable to that of Europeans. You know, rich Americans live about as long as average Europeans. So even rich Americans aren't doing as well as they might think. But look what happens as you go down the income ladder. Poorer men have hardly made any gains in life but men are doing better than women. The 40% of women at the bottom of the income ladder actually have a shorter life expectancy than 20 years ago. All the improvements in health care, clean air. Clean air in the Los Angeles area is associated with an increase in life expectancy of 4 years over the last 30 years. Cleaning up the air. Despite all that, poorer women have a shorter life expectancy. The first time that I gave this, I had just pulled it out of an article in the Brookings papers on economic activity. The first time I gave this, I said how I couldn't understand it. How is it even possible that people are dying and having a shorter life expectancy with all the improvements in medical technology and, like I said, clean air, etc. Afterwards, a woman came up to me and she said she had no problem understanding it. And when she told me, I was like, oh God, I'm an idiot. You know, a light bulb went off. She worked at a food bank. She said when people come in and there's not enough food for the family, who goes hungry? Mom. Is there a mom who will eat when her children don't get to eat? If you can afford only one prescription, whose prescription gets filled? The child's, of course. You would never take an antibiotic knowing that your child's strep throat isn't being treated. So what happens is mothers die caring for their children. Look what we've done. We've taken the most fundamental human value, the love of a parent for their child, and we've turned it around into a competition where somebody, the mom, dies for lack of money and lack of health care. And it's happening in America, the richest country in the world. People of color are suffering even more from all this. You know, the market turn in healthcare policy is particularly toxic for people of color, for reasons that are so obvious that I'm embarrassed to even have a slide for them, but I will anyway. Okay, discrimination leads to medical need. Poor people, people of color, need more health care, while they're getting less because of racist health care providers. And poverty means lack of insurance ability to pay. And when ability to pay is what determines whether you get health care, if you don't have as much ability to pay, then you get less health care.
That's right.
Yeah. There's no news here. Blacks are poorer than whites. Blacks are poorer than Asians. You know, they have lower wages. They have less wealth. This has gotten worse. While all working Americans have lost ground and wealth since 2008 and the market and the financial market crash, blacks have done worse. You know, partly because so many blacks are people of color are working class as against rich, but whites are richer than 20 years ago. Hispanics are a bit poorer. Blacks are poorer. Hispanics are a little bit richer. Blacks are poorer. The median wealth for an African American household in the United States is $3,500, barely above zero. Which means even if you're ready to mortgage your house to pay your doctor bill, you get a $10,000 bill. There's no way you can pay it. You know, if I get a $10,000 bill, you know, I'm unhappy, you know, but, okay, life expectancy is lower for blacks than for whites, men and women, regardless of income. Richer people live longer, but blacks are poorer blacks don't live as long at every income level. Blacks in the highest income levels barely have the life expectancy of whites just above the poverty line. This is racism. Two things here. racism and income. And blacks are suffering from both. And the market turn is exacerbating both by making healthcare depend on income and by taking healthcare out of the area of human rights, where we can go and say, yeah, there's an example here. Medicare, 65, enacted 65. What happened to segregated hospitals in 1966? They integrated. What happened to infant mortality for African Americans in the South in 1966? And deaths from automobile accidents. These things plummeted because suddenly we were treating healthcare and access to hospitals in the South as an aspect of human rights, so blacks could go to the local hospital when a few minutes may make a difference in your life.
That's right.
We've been going in the other direction with predictable consequences. You know, this is deaths from all causes. Here, you know, we're talking about poverty and racism. All causes. Non-Hispanic whites, average mortality rate is about 20% less than blacks. Or put it the other way, blacks' mortality rate is 20% above whites. Heart disease, cancers, stroke, injuries, not much difference in injuries. Blacks don't commit suicide, though. Whites are the ones who commit suicide, and American Indians. You know, cirrhosis of the liver, no difference. Whites get drunk as much as blacks. HIV, blacks get it a lot more. But overall, why is it that blacks die more of heart attacks, cancers? You know, they get treated later, and they don't get treated as aggressively because they don't have money and because of remaining racism within the American society. The uninsured rate, higher for blacks. Get rid of uninsurance. Give everybody access to insurance. And who's going to benefit the most? Blacks, which we only saw in the ACA, the Affordable Care Act. Those who are kept out of the system will benefit more when we open the system up to everybody. Share of non-elderly adults who delayed care. Half of African Americans delayed care because they could not afford it or could not get access to a doctor who would see them. 35% of whites delayed care. What happens when you delay care? You may get better. You know, as my doctor would tell me, people see me when they're worse off, and then they start getting better naturally, and they can give me credit. You know, he was half joking, because there is some truth to it. But often it's not. You get a lump in your breast, and you think, okay, I don't want to pay the copay, I can't afford it, I don't have the money, it will go away. Well, sometimes it does, sometimes it doesn't. African Americans get treated later for cancer, breast cancer. African American men get treated later for prostate cancer. African Americans in general get treated later for hypertension and less aggressively. They get the care later, and that kills you. Here's breast cancer mortality, significantly higher for blacks than for whites, because African American women go to the doctor later. And when they do go to the doctor, they're treated less aggressively, even though it's further along, and they need more aggressive treatment. Only improved Medicare for all can make health care a human right, equitably delivered to everybody. Give those with less access to market wealth more access to care, and will allow us to address other sources of inequality in access. Here's what would happen. This is just one proposal. If we fund Medicare for all largely with a payroll tax, plus some tax on non-wage income, it's not the most progressive funding scheme. It's one proposal. Some of you may have seen the Democratic presidential debate. Elizabeth Warren needs a plan. She should have had it already. I don't understand it. But what the hell? I published this. She could have just grabbed it. And this gives the net change in income by income level. The biggest changes will be for middle-class working households, lower middle-class working households. The very poor don't benefit that much because so many of them are already on Medicaid, so they're not actually spending that much on health care. But as you go up to the working class, you know, truck drivers, carpenters, janitors, factory operatives. I mean, these are the people who will benefit the most. You go up higher and people are going to be paying more taxes. Because how do we pay for health care now? Premiums, co-pays, deductibles. Economists call these lump sum taxes. In popular parlance, you could call these poll taxes because everybody pays the same amount regardless of income. We banned the poll tax for voting, although Florida and other states are trying to bring it back. But we banned, the 24th Amendment banned the poll tax for voting. But we keep the poll tax for health care. Everybody pays the same amount. The average family health insurance plan provided by a private employer cost about $20,000 last year. $20,000 lump sum, regardless of whether you are a janitor earning $23,000 or the chancellor at the University of Massachusetts earning $500,000. His $500,000 income allows him to pay his premium without thinking. The janitor, it's a big deal. So changing to a payroll tax that's related to your income will be a big boon for these middle-class working people. You get higher up the ladder, you know, they're going to be paying more and more. Yes, a millionaire, Bill Gates is retired, but Jeff Bezos at Amazon, the richest man in the world, I understand, although he's getting a divorce, so maybe split up a bit, but he'll get it back. You know, under this plan, he would be paying a lot more than $20,000. Yeah. But the janitors at Amazon would be benefiting. Replace markets with rules grounded in democratic and civil rights. What an idea. You know, instead of giving health care according to your ability to pay, instead of treating it as a commodity, we're going to treat it as a democratic right that all Americans should have. You know,
That's right.
I mean, I live near Concord, Massachusetts. You know, the rude bridge that arched the flood, where the embattled farmers stood. Concord is also the place that, in some ways, gave birth to the abolition movement in the United States. You know, Louisa May Alcott of Little Women, her father was one of the leaders. I can do better than that. My synagogue used to be the church for Emily Dickinson. The Republican Party, not the party of Trump, the party of Abraham Lincoln, was founded in her father's hotel suite in Washington, D.C. in 1855. These are people who did not fight so we could have consumption. That embattled farmer stood up against the most powerful empire in the world, and the abolitionists stood against the slave power, which dominated American politics and dominated the Atlantic economy. They stood against it for civil rights so that everybody should be treated as a human being worthy of respect and, at a minimum, worthy of health care. And that's what we're fighting for improved Medicare for all. We've been fighting for it for 100 years. I hope we'll be making progress soon. But we will keep on fighting whatever it takes. And thank you very much for having me. Yes.
So, on the last debate, it seemed like the media got hung up on taxes versus cost. And it seemed to me pretty simple to explain that if your taxes go up $5, but your medical care is free, that would be a better deal, but I didn't hear anybody say that.
Oh, God, neither did I. And I'm very disappointed. I wish Elizabeth Warren would talk to you, because you got it.
I'm available. Elizabeth. I'm available. I'm right here.
Look, we pay for health care out of two pockets. My right pocket are private taxes that I pay to Aetna or Anthem, Blue Cross, or whatever. And I pay private fees out of my right pocket. My left pocket, I pay taxes. Okay, you put them together, that's what I'm paying. The private taxes to the insurance industry and co-pays, etc., and the public taxes. That's what I care about. How much money am I spending? I don't care if you raise my public taxes by $1 if you cut my private taxes by $2. I mean, that's simple math. $1 plus minus $2, I'm better off. And Elizabeth Warren should listen to you. You've got it.
Here you go.
I think that when we're talking about taxes and deductions and payroll deductions, most people who are working, you have a certain amount of your payroll deduction for insurance, plus your employer kicks in. Usually you pay about 1/3 and they pay about 2/3. Yeah. And I understand that the tax laws will change so that that 2/3 that's an employer contribution at some point will become considered as earned income that's going to be subject to taxes. So taxes will go up even if we do nothing. We're already paying most people pay about 7 or 8% for FICA, which is already contributing towards Medicare, Medicaid, and Social Security. So I think it's a complicated question when we talk about will taxes go up. They're going to go up, one way or the other, whether we do Medicare for all or not. I think that it's one of those things that it's a gotcha question in a debate scenario because it's difficult to answer in those little 30-second time frames that you have to speak, because you have to talk about a lot of complicated pieces and moving parts. It's not a simple answer.
Yes, you're absolutely right. And there's another aspect even beyond what you're saying, which is what's going to happen if we don't change the system. Because costs, your right pocket and your left pocket, are going to rise. The Center for Medicare and Medicaid Services projects basically a 5.5% a year increase in spending on health care. A lot of that is they project rising prices for health care. No projection of significant increase in utilization, but we're going to be spending more because they're just assuming that we're going to continue to have rising prices. More money going to the insurance industry, more money going to the profits of the hospitals, whether they're non-profit or profit-making, this works out the same. And as those costs rise, we're going to be spending more, we're going to be paying more. So our taxes, certainly our taxes from the right pocket, the private taxes, they're going to be going up. You know, the comparison should not be with, although if we did Medicare for all right now, we would save money. But even that understates the benefits of improved Medicare for all, financial benefits, because improved Medicare for all will also give us the means to control healthcare inflation, restraining those rising taxes that we are going to be paying unless we do something.
Dr. Friedman, you spoke of the inequities and the disparities when you reflected on the chart of African Americans. There are approximately 39 million African Americans. From what you showed us today, to build a coalition of conscience, if those 39 million voices seen that there was no equality for real, and they understood the disparity, do you think we could build a movement of equity that moves towards bringing this to fruition quicker?
Oh, absolutely, and I believe the Congressional Black Caucus has been supporting Medicare for All. Is that right?
Poor People's Campaign.
Yeah, the Poor People's Campaign has been very active. You know, African Americans have been the heart of progressive politics before I was born. And I would flip your question a little bit. Without the support of the African American community, this is going to be a really hard struggle. With it, we can do it. We're taking on, as I said, some of the most powerful interests in America. But we're a democracy. You know, we've done it before. And, you know, with the African American community behind us, we can do it.
And David did bring down Goliath, right?
Yes.
Come on.
Yes. To the rest, through the exchanges and the Medicaid expansion. So it was good. That said, the Affordable Care Act is trying to fit a square peg in a round hole. We have a system of private health insurance which is constantly looking for ways to manipulate government, through regulatory capture, and looking for ways out from the restrictions in the Affordable Care Act. Of course, we fight all the time to protect it, protect the games won. But it's not enough, and it can never be enough, because the fundamental problem is the treatment of healthcare as a commodity to be distributed through private insurance and for-profit institutions, you know, whether they call themselves for-profit or not. One of my friends says not-for-profit hospitals are not taxed hospitals, but they basically behave like the for-profit hospitals. Because that is what we wanted in our public policy. Our public policy has been that everybody should be out there trying to make a profit. You know, everybody should be treated as a consumer, and every producer should be a for-profit producer. You know, we should commoditize everything, and that is the fundamental problem. Our choice is, ultimately, our choice is commodities or human rights. The Affordable Care Act, blessed be those who got it through. What a struggle it was. It's still based on the commodity side of the equation. You know, we need to cross over that bridge to human rights.
It was a foot in the door. That's what I thought. Because you're never going to get it, as you said. You've been fighting this for 19 from Teddy Roosevelt. Also, the one final question is where, I think the world of Elizabeth Warren, and I just wonder where, I mean, if she's saying that the middle class will get a tax reduction, I mean, have you analyzed that, or is that a flop, or what?
Well, I'll start with that. The middle class will get a spending reduction. They'll get a cost reduction. Technically, if you call taxes, if you're only talking about public taxes, this left-hand pocket, then yeah, of course they're going to have to go up. You know, by my estimates, which are on the optimistic side, we need $8 trillion in additional federal revenues over the next 10 years to fund Medicare for all. $8 trillion. You're not just going to get it from billionaires. You know, somebody on Monday, somebody who may or may not be talking to Elizabeth Warren, asked me, well, how much could we get from millionaires? And, you know, I put in, well, let's say we give them a 10 percentage point increase in their income tax rate. You know, well, that would get us $1 trillion over 10 years. But that still leaves a $7 trillion hole. So you're going to have to go to people who make less than $1 million. But if you talk about cost for the middle class, then it's not just the left pocket, it's also the right pocket, what we pay for private health insurance. Now there's a real problem here, which goes back to something you brought up, that employers pay for 2/3, 3/4 of your premiums. So years ago, after the debacle in Vermont on a single payer plan, I went around to my colleagues. Everyone is a smart people. Several of them gave me, well, I think it's like $450 a month for my premiums. No, dumbass. $450 a month is a quarter of your premium because your employer, our employer, is paying 3 times that much. And you have to add in your deductible, if you meet your deductible, your copay for every time you go, which I understand people don't necessarily remember exactly how many times they went to the doctor. But you know, you have 4 kids. If you have 2 kids, 4 of you in the family, you go 4 times a year. That's 16 visits at a $35 deductible. You can do the math. You know, which none of my colleagues did. The closest was a health economist who at least had an idea of how much the premium was, but he was off by thousands of dollars. So, just a second. So yeah, we should learn from other countries, and we should adopt a position of modesty. I mean, I love the United States. It saved my family. You know, I grew up, you know, the flag of Iwo Jima and the Union and Gettysburg Address and all that, and the soldiers, including a black division in the U.S. Army who liberated concentration camps. So, you know, I appreciate the dream of America, the promissory note that is America. But we can learn from other countries. We should adopt a position of humility. You know, other countries have made the transition to a national single-payer system. Canada did 45 years ago. Taiwan did 20 years ago. You know, we should look at what they did. And yeah, we should try to adopt the best because we are number 12 year after year.
We're going to
Like Humana, Blue Cross Blue Shield, are they still a part of that healthcare type system, or do they go away?
Oh my, yes. Short question. To the employer contribution, that's a really good question. And in theory, that should turn into wages. Because employers are counting this. I mean, I've sat in labor negotiations as a consultant, and the employers have always talked about, well, this is compensation. And the unions have said, well, this is what we get in wages. You shouldn't be counting the health insurance premiums. Well, if they're going to count the health insurance premiums as compensation, they really should be turned into wages. Will that happen? Economists assume, oh, yes. You know, for reasons we can talk about. You know, it's kind of a standard problem in first-year microeconomics in graduate school. Will it actually happen in real life in a country with chronic underemployment? Maybe not. You know, so that's a real problem. They may just pocket it as profits. The second part is what would happen to health insurance companies. Well, largely they'll be gone. I mean, Medicare employs health insurance companies to distribute benefits. Yeah, and that would probably continue with the improved Medicare for all. But they're not going to need very many more people because they're already set up. You know, processing checks is really cheap and easy. So most of those people will be out of work, which is a major issue. Plus, there'll be as many as 2 million more people out of work in provider offices. That's where we're getting some of these savings, by not employing these people, but then they're unemployed. The bills in Congress all provide for extended unemployment insurance and job retraining. You know, I mean, it's a good idea, but the main benefit for them is that when people aren't spending so much money on healthcare, they will be spending the money on other things. And when people are healthier, Americans will be more productive. So that will increase employment. People have not modeled this very carefully. I'm not sure anybody has actually modeled it other than myself. And my models are not perfect by any means, though I have a graduate student working on a paper on this. But it's reasonable to expect that employment will increase overall, which may not be much consolation to somebody who's losing a job that, oh, well, there'll be lots of other jobs. So that's why we need to help people with that transition, if nothing else, to reduce political opposition.
a final question, and then the answer, and then we all proceed to the other side down out this door
best case scenario, Warren or Bernie gets in and they're able to push this through. What does that look like for the overall market economy? I mean,
Oh, you people are asking the right questions. Close to $1 trillion in market value goes poof. People see this in their 401k plans. Health insurance companies, and it's not just health insurance companies, trillions of dollars in market value in drug companies, they're going to take a big hit. There are private hospitals on the New York Stock Exchange. They're going to take a hit. It will ripple. Madison Avenue makes a lot of money on advertising. The media, oh my God. My mother-in-law used to, she lived in Amherst, and my wife was kind of in charge of her care while she was still able to live in a home. We would go over there, and I would camp in front of the TV in the afternoon and watch reruns of Buffy the Vampire Slayer. And the commercials. They were all advertising the drugs. You know, when the drug companies aren't making so much money off of their prescriptions in the U.S., they'll cut back on that. That's going to hit the media companies. You go on through the economy, it's going to be a major hit to financial services. Balanced a little bit, there'll be fewer bankruptcies. And that's going to help the banks a little bit. But, more than $1 trillion passes through health insurance companies every year. That money goes to banks. Banks are getting money off of that money. So, in my forthcoming book, The Case for Medicare for All, I talk about it a little bit. It's an issue. One proposal, and I'm serious about this, one proposal that I'm not supporting it, but I'm bringing it up, that some single-payer advocates have made is we buy the damn health insurance companies.
one nice bailout.
That would be in the area of $1 trillion. Bond that, you pay it off over 30 years. It's comparable to what the British did when they emancipated slaves. They paid 40% on the value of the slaves. My first book was on slavery in the Caribbean, analysis of Trinidad. It kind of, it's galling to think that we'd be paying these vultures. I was going to say vampires. That would work too. But it would stabilize people's portfolios who have invested in health insurance companies on the idea that, well, this is a secure investment. I'm 62 years old, and I'm 64 years old, and my wife's retirement money she won't invest in arms companies, she won't invest in fossil fuel companies. So what is her portfolio loaded up with? Drug companies and health insurance. So, but you're absolutely right, and we need to think about it much more.
Warren or Bernie's plans, do they deal with that particular?
No, they don't deal with that at all. They deal with the unemployed, but not with the stock market, financial markets.
Okay, that was the last question. And Dr. Friedman will be on the other side. Dr. Garrett, you raise your hand. Dr. Garrett's going to be on the other side. You're going to be on the other side with us. And then Sister Kay will be on the other side. So any questions, Dr. Friedman will be over on the other side. So I'd like to thank Westchester Street Baptist Church for allowing us to
Thank you.
The refreshments are prepared by Sweet Peaches, a local restaurant right in the neighborhood.
Amen.
Brother Bob Cunningham and Brother Antonio Wycliffe, and of course you, Dr. Friedman. Let's give him a round of applause. Turn, go down the hall, and you will see some tables.
I hope you enjoyed today's presentation. And remember, Medicare for all means health equality for all. That was our speaker. We thank him so much for coming. And don't forget, if you're looking for peaceful entertainment solutions, hire me. My company offers many things. Thank you for tuning in to today's show. And have a beautiful day. Peace.